Thank you, Chairperson. Assalamualaikum and good afternoon, my respected audience. Thank you also to the organizing committee for inviting me to speak in the 36th Annual Congress of Malaysian Society of Nephrology 2021. The topic given to me is on polypharmacy in chronic kidney disease. Can we do better? Right, I have divided my presentation into 3 parts. The first part is looking into the context of polypharmacy, followed by our concerns of polypharmacy in CKD and the strategies to overcome polypharmacy. To start off my presentation, I would like to share with you a scenario of Mr. AHA, 43-year-old CKD patient at stage 4. He is currently on 14 medications a day, requiring 20 doses in a day. He has hypertension and type 2 diabetes, gout, 2 to 3 attacks a year, and has been treated with for H. pylori 1 year ago. When he presented to the clinic, he complained of having shortness of breath over 1 week, nausea and vomiting. Medication assessment showed poor adherence and drug knowledge, right? So we're going to remember Mr. AHA and try to apply as we dwell into the context of polypharmacy. Right. Polypharmacy means the concurrent and routine use of 6 and more medications, including drugs that were prescribed or self-purchased as traditional and complementary medicines. The number 6 that is defined here is based on a population study that shows people taking more than 5 medication has increased risk to experience an adverse drug events as compared to those who are taking fewer medications. Yeah, so that's where the number 6 come from actually. However, some studies find there is no correlation between polypharmacy and increased hospital admission. So what I want to highlight here is the term inappropriate polypharmacy, because most of the time polypharmacy or giving less than 6 medication may not be applicable in clinical setting based on the patient's disease state. Yeah? So polypharmacy, when it is inappropriate, it is characterized by overprescribing, incorrect prescribing, or underprescribing, and this is regardless of the number of medications that the patient takes. Because it is the inappropriate pharmacy that actually correlates with the adverse clinical outcomes. And the first in the list is the increased risk of medication-related problems. And we do know that MRP, not only in CKD population, but also all people with chronic diseases, has a significant effect in their quality of life. Yeah. So inappropriate polypharmacy does not only cause that, it also increases the healthcare costs because of the requirement, diagnostic tests and procedures from treatment failure, add up to the patient's existing comorbid list, and also associated with other adverse clinical outcomes. Let's move on now to the concern of polypharmacy in CKD. In CKD, due to the nature of the disease progression and declining kidney function, it is somehow necessary or to have more multiple medications with the intention to improve the patient's quality of life. It is quite a difficult task, to reduce the medications that CKD patients require at the same time with the intention to have a better quality of life for the patient. So that's why the prevalence of taking more than 5 medications in CKD population range from 30 to 90% depending on how they define and calculate the prevalence. But we do know that the number of the medication increase with declining kidney function. What I'm sharing you here in this slide are the commonly prescribed medications for CKD people in Malaysia, which seems does not have much difference than what are the commonly prescribed reported from the Western countries. Medications that are prescribed to CKD patients are rationally and justified. It is required for their treatment. But number 2 that we should ask ourselves is, are the way the drugs are prescribed and supplied to our patient contributes to inappropriate polypharmacy? Because there are 5 concerns of polypharmacy in CKD. Number 1, we do know patients CKD has a high pill burden. Yeah, people on dialysis, for example, requires more than 10 medications. This contributes to non-adherence. Either it is intentional or non-intentional, it is a phenomenon which is really difficult for us to tackle, even though in the era of IT now, yeah. Number three, the concern is related to the lack of continuous medication review. Even though medication review is advisable, is advised and recommended by the KDIGO guideline to be conducted at every clinic appointment. But we do know in a clinic busy hospital schedule and patients appointments, it's quite impossible for us to offer effective medication review at each hospital appointments. Yeah. The fourth concern about polypharmacy in CKD is the debatable use of pharmacotherapeutic agents. The three examples that I would like to share here is whether or not should we consistently continue anticoagulants in patients on dialysis with underlying atrial fibrillation. How soon should we start activated vitamin D in advanced CKD to ensure less risk of hyperparathyroidism complications, and also whether or not there is a need to have magnesium supplementation in CKD MBD to start from the early stage. Yeah, and the last but not least is the concerns on the use of OTC, traditional and complementary medicine, especially in this era now where we have a booming of information available to almost all patients, yeah, everyone. The influence of online market, we are still in the learning stage of how can we effectively regulate online medications and advertisement trading. Yeah, and we are having some challenges to compile safety and efficacy data, as well as the pharmacokinetic and dynamic data of OTC and TCM products when it comes for use for people with impaired vital organs. This goes to the third section of my presentation. This table nicely summarized for us the ways we can manage polypharmacy in CKD patient. We do know that reducing pill burden and disseminating adequate relevant information to our patient do have positive impact in the overall treatment plan, yeah, and also in reducing the incidence of polypharmacy. But why are the polypharmacy problem does not giving us a significant reduction over the years? So perhaps what we should look further starting from now on is how else can we do better in what we are already doing? There could be some other ways to do it, yeah? And what new innovation can we invest on? I would like to highlight three ways that we can do better. Number one is to minimize the number of prescribed medications. Two is to enhance collaborative medication management. And number three is to promote the use of health technology when we talk about medication adherence. Let's dwell into the first part, which is to minimize the number of prescribed medications. One of the intervention that we can look into seriously is the home medication review program. This program has been in the service for more than 15 years, I would say, but it has not been actively incorporated into the dialysis home visit yet at the moment. We should look into whether we can incorporate HMR as one of a mandatory activity during dialysis home visit, yeah, because it offers the pharmacist conducting HMR can do a follow-up education and provision of an updated medication list at patient's home. We can also rectify medication-related problems that the patient are facing at home, rather than having it identified retrospectively based on what the patient can recall during hospital appointment. And HMR has shown to be effective to reduce waste, especially to reduce overstocking and expired drugs at patients' home. It enables us to actively identify patients with irrational polypharmacy and to adjust their repeat prescriptions as well as to adjust their date for next medication appointment. Right. The study by Professor Azmi regarding home medication review and return medications, we see here that the types of medication that we collect from patients' home available accessively, and the type of medications that the patients voluntarily bring to the pharmacy counter us. And these are also the type of medications that we see having the potential for us to amend or de-prescribe in the CKD population as well. So this is another method that we should take the opportunity to look into seriously, yeah, because how in this era that we can offer effective medication reconciliation, because this method has been made mandatory at many hospitals. And the one that I had the experience to practice myself is in Australia and in the UK, where this stage of medication reconciliation is embedded into the patient care process. It is regulated and the policy comes from top to bottom. Of course, this has to be tailored to the policies and regulation of the specific country healthcare system, but it's not too late for us to look into this systematically, yeah, because medication review, medication reconciliation, when we are managed to conduct effectively in a consistent manner, yeah, it would be able to generate quality information for clinicians to systematically and safely de-prescribe regular medications that the patient has been taking, okay? And having a very good and systematic medication reconciliation program enable the physicians to de-prescribe effectively and safely. So there are 5 steps, yeah, in medication assessment to enable safe and effective de-prescribing for CKD. The first one is, of course, to assess the kidney function. That's the starting point to know at what level they are. Then we can use the strategy of effective medication review and reconciliation to obtain an accurate medication history. This will generate information for the clinician to adjust the current regimen. And one of it is to de-prescribe effectively and safely. And once these actions has been taken, then it is the healthcare team responsibility to ensure that the drug therapy are well monitored for its effectiveness and safety effect, okay? What I'm sharing here are the commonly prescribed medications that may require to be adjusted in people with CKD. It is not exhaustive, of course, but it gives us some idea that diabetic medications, cardiovascular medications, pain medications are the top in the list that we have to see a red flag, yeah, when we do reconciliation. Going back to Mr. AHA that we look into during my early presentation, from having 14 medications a day and 20 doses, through proper reconciliation and de-prescribing, he is left with 8 medications and 13 doses, with medications and adherence counseling program, and also to initiate the long-term plan of RRT discussion. Right, so this is a good example of collaborative medicines management. So this goes to the next point of the intervention that we can look into to minimize polypharmacy in CKD, which is CMM in short. Okay, so what is CMM? It is derived from the WHO definition of interprofessional collaboration, where we have multiple healthcare workers from different professional backgrounds working together to deliver the best care. So this is not something new, we do know that. But what we want to imply is that how can collaborative medication management here can incorporate the pharmacist's skills and abilities to complement the team, okay? And to sustain a CMM in the long run requires intervention at many healthcare levels. As we can see here that in the practice level, we are quite good. I'm speaking from the point of our local practice. We have the widely available service in major hospital is the medication therapy adherence clinic for patients with chronic diseases, including pre-dialysis, dialysis, and kidney transplant. And I would like to share with you a good example of how CMM can be taken into higher level is through the pre-dialysis education program. So I take here several countries for the sake of discussion in today's presentation. Regardless of the name of the program that incorporates pharmacists as a team member would have a better medication management entity or outcomes as compared to the program which does not include a pharmacist into the team member. Okay, right. Talking about adherence, the first three ingredients of a successful intervention to improve adherence has been tried out for so long, right? How are we going to use the tools? What tools can we use to have a better opportunity for the patients to self-monitor themselves outside the hospital ground, to have them engage in their treatment, not only during hospital visit, but also as part of their day-to-day habits. Yeah, at the moment, they are engaged in the treatment only when they are present physically with the healthcare provider. Yeah, there seems to be a disconnection between the period after the clinic appointment until the next appointment or the next hospital visit. So there's a gap there. Yeah. So this diagram gives us a very good a timeline on the evaluation of the strategies that has been used to improve non-adherence towards medication. In the 1990s, our strategies was to give conventional counselings, yeah, on the knowledge of the medication and disease and how to self-care at home. And as we go into the 2000 era, it is the intervention or the strategies is to have a shared decision making, to have the patient decide for themselves what they want to do, what the options are there. And we give them motivational counseling approach as compared to the previous conventional counseling technique. But at the current moment, there's no way that we can avoid the use of health technology, because having real data is important for clinical decision making. And we want a situation where the patient can effectively self-monitor themselves as a habit in life, rather than as a habit before a clinic appointment. Yeah, and we're now looking into how this adherence can improve quality of life, which means how can the interventions that we are proposing at the hospital ground are affecting their activities at home and their daily life activities. So, having said that, when we talk about health technology, it refers to any IT tools, yeah, that can be used to improve the overall quality of care that we provide for the patient. This would include as well non-adherence. There are 5 innovations in technology when we talk about non-adherence. Yeah, how can we improve it? Number 1 is to look into predictive analysis, where we have data through recording and detecting patterns to inform future clinical decision making. Number 2 is to invest into mobile tracking and gamification apps. So innovation number 2 does not only improve the communication, yeah, between healthcare provider, patients, and their family members, but it is something to introduce as a reward, rewarding the people who adhere to their medication. Or treatment plan, in fact, does not have to be medication per se, by having this positive virtual competition between the people of the same cluster or the same group. Okay. The third innovation is to have convenient access and drug delivery. This is part of healthcare consumerism. Talking into our local practice, the pharmacy service division have a very stable pharmacy value-added service, where we can post the patient, drive through, post the drugs, drive through facilities, locker for the patients to have in the hospital. But from here, what we need to look further is, would there be any potential to have a pill pack delivery? Or how can we combine telemedicine and telepharmacy to come up with telehealth prescription where the patient does not have to come physically to the hospital to renew their prescriptions. Yeah, so this would be a better step moving forward. And also the list of medications that we are able to post to patients' home. It's time for us to review so that we can look into the logistic around it. At the moment, cold chain items are a bit difficult. We don't offer cold chain item delivery by post, but if we want to embark into innovation, so these are the things that we can look into as well. The fourth innovation is the smart packaging, smart bottle with adherence tracking, personalized pre-packed blister for chronic medications. I know that Australia has embarked into this for so long, where patients can ask their bulk medications to be blistered packed individually by week or by month, either at the hospital or can they walk into any community pharmacy. It is more hygienic, less oxidized of the medications, and safe where it is labeled with expiry date and done by a trained professional. Okay, so this is also one option that we can make available for the people in Malaysia especially. And ingestible solution, this is still under research to use in patients with complicated non-adherence situation where we have RFID pill detectors to detect administration of medications at home. And when we talk about technology, in pharmaceutical care, the focus is on the mobile health. So mobile health is a low-hanging fruit that we can straight away use nowadays, where we just having the mobile smartphone is good enough for us to start the mobile health. But what we have to think of is, at the current moment, the mobile health offers information across multiple applications which does not sync or interface with the medical records. Yeah. So in the future, what would happen when you talk about opportunity to improve adherence is to have the mobile apps information translated into the medical notes and give us the opportunity to have an updated patient profile whenever they go into different hospitals or clinics, okay, to receive patients' adherence specific data and also maintain adequate pharmacy stock for their needs in real life scenario or real life time, yeah, rather than retrospectively having it recorded. Okay, so this comes to my last slide, which is the take-home message. Number one, polypharmacy in chronic diseases, including CKD, is unavoidable. Sometimes it can be a necessity. So number two is that adverse clinical outcome arise in situation of inappropriate polypharmacy. So rather than we focus on polypharmacy, let's focus on the inappropriate part of the polypharmacy, since having more than 6 medication would be unavoidable in most of the clinical settings. And the strategies to prevent inappropriate polypharmacy includes improve the conduct of current practice and investment in healthcare technologies, and to enhance the data quality for clinical decision making. So with that, thank you for your attention. I would like to end my presentation here. Thank you very much.